order to take change forward, you need authority to do so. You can. I'm not necessarily talking about, the traditional sort of hierarchical boss at the top, everybody else underneath. He shouts, jump, and everybody says how high. But you cannot expect to get people to do things which, broadly speaking, they don't want to do or are going to find very difficult to do without having some authority in the process. So what have I found is important for trying to create that authority where what might be called normal, natural systems of authority aren't there? First and foremost, and I think this is perhaps the most important thing, and we don't do it very well, and that is to create a compelling case for change. A compelling case for change that has powerful emotional resonance for people. So, the NHS is something that creates an emotional response in people, and to get people to agree that it needs to change, you have to engage with that. Now, I'm not talking about just empty rhetoric. I'm talking about a case for change that can be built up, that has a story to be told, that has emotional resonance for people, and that can be backed up by the data. So the example that I used the other night, and I still think it's a good one actually, was in northwest London. We're trying to make a big change there about reducing the number of hospital beds and increasing the investment in primary and community care, and creating better care pathways, integrated care pathways for patients is essentially the story. Now, if I went into a public arena and said that, it's completely meaningless, right? Completely meaningless. It doesn't engage anybody. Nobody's going to think it's important. They'll think it's bureaucracy, and they'll just see me as a suit. They'd see me as a suit anyway, arguably. But whereas if you say we are currently amputating the limbs of 200 diabetics unnecessarily, that engages people's interest. Second thing, to support that, not without evidence, use data, transparency around data. We're doing much better on that. I think Bruce Keogh has done a fantastic job on that. There's some great evidence for that now in primary care as well. I think we're doing so much better on that than we've done before, but there's a heck of a lot further to go. Third thing, developing clinical leadership. Again, we're doing much better on this. We've got lots of fantastic clinicians willing to step forward and lead change. I do think it needs more doctors and more doctors willing to be out front. The evidence says that the public are willing to believe doctors. When they stand up and articulate a case for change, the public will believe it in a way that they won't with other professions, and they certainly won't with bureaucrats. So finding ways to support doctors in leadership to come forward and not just do these changes once, but to do them repeatedly is a massive challenge. Resources and priorities, really tricky. We're bad at setting priorities in the NHS because everything's important. My experience has been that it is the job of leaders to be much, much more assertive about priorities, and then sticking to them and reinforcing it through things like appraisal, all sorts of interventions that you have with your staff and your colleagues and your partners. Those interactions need to reinforce what the priorities are, and everything that comes from the top down mitigates against that. Last thing on my list of how do we get authority for change would be to think appropriately about scale and plan accordingly. So if you're going to try and take forward a change programme that affects, let's say, acute hospital services, a traditional sort of hospital reconfiguration programme, in my experience you're wasting your time unless you look at a population of 500,000, because you cannot manage the conflicting interests that exist in a credible way. It just can't be done. If I think about the London stroke programme that we run, that was run for the whole of London, and I think if we hadn't done it in that way, we would not have got agreement. There would have been, so if you tried to reorganise stroke services in Ealing, just for Ealing, for example, your story would have been, we're going to shut the stroke unit. And, no way would you have got the population of Ealing to see that that was a good idea. Talk about the population of London as a whole, the care model for London as a whole, it was possible to see it through. I think it's possible to see things through in local systems where you've got hospitals, primary care, social care, community care together saying this is what's needed for our community, because you've got a balance of interest and you can show how the change overall can support the whole improvement plan.